Hi, everybody. It's Dr. Andrew Gums, editor-in-chief of the journal Artificial Intelligence Surgery. This is episode 67 of our podcast, Artificial Intelligence and Cybersurgery. I'm here today with my co-host, Dr. Vincent Grasso, soon to be Professor Grasso, I believe.
Yes, thank you.
So we're the podcast of the first journal dedicated exclusively to surgery and artificial intelligence, and I will let Vincent introduce our next guest, who I'm very excited to learn more about, because we have a lot of friends in common and similar passions, it sounds like.
That's fantastic. Hi, Andrew, and good evening, I guess, for you, Tiger. So we have a very interesting guest on episode 67, as Andrew said. So welcome to Dr. Taiga Wakabayashi. He's a hepatobiliary surgeon at the Center for Advanced Treatment of Hepatobiliary and Pancreatic Diseases at the Ageo Central General Hospital in Japan. And welcome to our podcast, and looking forward to learning about all the interesting things you're doing. So welcome.
So actually, I'd like to point that out. So Vincent, you're on New York time right now.
Yeah.
I'm in Paris, so it's about 3:38 p.m. in the evening, or I should say, 15:38. So Taiga, what time is it for you in Tokyo?
Actually, it's 30 minutes past 10 p.m.
Oh my God! So we will let you go to bed. Let you go to bed soon. So
No, it's okay.
so
Yeah,
so
my
Taiga,
pleasure.
you're an HPB surgeon and you have a great interest in AI. Can you tell us a little bit where you're from? Are you from Tokyo?
Yeah.
Where are you from, and why did you go into surgery, and why HPB surgery?
Okay. So yeah, actually, currently I'm working in Ageo Central General Hospital as a kind of senior attending surgeon. And my interest is like, of course, HPB surgery, and mainly I'm doing like robotic procedures now. Actually, my motivation initially, why I get into the HPB field is actually, my father is a famous HPB surgeon, but actually, I originally,
Father is Go? Your father is Go?
that's right, yeah.
Oh my God!
You didn't know.
No, I did
didn't know
not
that.
know. Yeah, oh, that's impressive. Oh, that's
That's
great.
okay. That's okay. That's okay.
Yeah.
All right.
I
Yeah.
figured Wakabayashi was a relatively common
Wak
name in Japan,
Wak
so I didn't think to ask.
Wakabayashi is less common in Japan, actually.
For me, it's one of the
Anyway,
Japanese names I know, so it sounds common to me.
yeah.
Because your father is
Okay.
so famous.
Yeah. But actually, I was working in IRCAD France in 2018,
Yeah.
and it drastically, changed my,
Perception.
perception to AI and AR in surgery.
Yeah.
And at that time, I already have a great interest in HPV surgery. And at that same time, I, went deep dive into the AI and AR field in close relation to HPV surgery. And now I keep going in the same way. So that's it, actually. Yeah.
And so I presume that
Mhm.
your English is so wonderful, because were you speaking mainly English in at IRCAD, or mainly French?
English. Yeah.
Okay. And you were there for
Just
how long?
greetings in French.
Sorry?
Just greetings in French, like yeah.
Well, no, it's impressive to go from Japanese to English. That's plenty. Trust me. I can't imagine doing that. That is. I tried to learn Georgian language, which
Mhm.
the alphabet is completely different. It's one of 14 alphabets. The Republic of Georgia, and I must say it hurt my brain. So I shifted, and I've been learning German ever since. And German is so much easier. And Vincent, as you can imagine, German is very difficult as it is. But when you have to
Yeah.
learn another alphabet, and
Mhm.
my goodness, it's a whole can of worms. So how long were you at IRCAD?
Just 1 year.
Yep.
Yeah.
And
Mhm.
I saw that you did a PhD. You did that at your university?
At Keio University. Yeah.
Yeah, at Keio University.
Yeah.
Okay. And
Mhm.
your father is in northern Japan, no? Or did he move?
Yes, he moved in almost like 15 years ago. Yeah. No, sorry. Yes, yes. No, 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 sorry. 10 years ago. Yeah.
Yeah.
And now working in the same hospital actually
Oh, so he's
with
he's
me.
he's in a private hospital. Oh, that's fantastic. That must be wonderful and terrible at the same time. The reason I say that is my father was a surgeon, so I can relate to how wonderful and also stressful that can be. So, I
All
didn't
right.
know much about private practice in Japan. Could you give me an idea about what percentage um, of things are done in the private practice world? I mean, Vincent, in America, how much would you say is private practice? Is it 50-50? Is that a fair guess?
Maybe more. Yeah.
Maybe 60-40, something like
Yeah,
that?
maybe 60, 40, 70, 30. It's pretty high.
Maybe even 70-30. So in Europe, in Italy, in Milan, I would say it's probably, I'll just say 50-50 to make it easy. In southern Italy, it's like 5%. In all of France, I would say it's probably on the order of 50-50 actually also. So
Wow.
in Japan, how many people go to private practice? Is it 10% of the population? Is it 50% of the population?
I guess like a 50-50,
Oh, it
but
is.
it's not, but
Oh,
actually it's not work as private and public like in your countries.
so
We are covered by same insurance, actually,
yeah.
same governmental insurance, but we said like it's working in a private or public hospital. So it's quite different, maybe. Yeah.
Well, in a
Mm.
private
Hmm.
hospital in
Mm.
Japan, do you get
Mm.
paid the same amount for a Whipple procedure as in a public hospital, or is the pay schedule different?
Actually, it's the kind of same.
Oh, it is. Okay, so it's like
Yeah.
so they have that
Mm.
in Italy. It's a very strange thing for Americans like us to understand, Vincent. It's a
Yeah.
private hospital, but the reimbursement is the same as in the
Yeah.
public. So it's
Exactly.
owned
Yeah.
privately, but the reimbursement is the same, which is it's
Yeah.
we don't do we have anything like that in America, Vincent?
No.
I don't think we have that. In France, you know what? In France, we have it also, but we also have private practice like the American version. So we have all three flavors. So are you
Hmm.
are you more interested in liver or pancreas, Taiga?
Let's say liver. Mm.
Liver. Okay.
Currently, yeah.
And in artificial intelligence, you mentioned that you like augmented reality. Now you worked with Patrick Passot, I saw.
Exactly. Hmm.
So you were mainly at the EHU or you were mainly at IRCAD? Were you mainly EHU or were you at
Yeah.
both?
I'm mainly AirCAD actually. Yeah.
Oh, you were mainly IRCAD. Okay.
Yeah. Hmm.
So I think you even wrote some papers with Riccardo Mameo in Bari, Italy. Did you ever meet him?
Yeah. Yeah. Yeah.
Okay, great.
Good friend. Yeah, of mine.
Yeah,
Yeah. Hmm.
yeah, very nice. So
Yeah.
tell us a little bit more about what are you doing in AI now? Now you're at a public hospital, a private hospital. Do you have
Yeah.
dedicated time to do research or no?
Yeah. Actually, I'm doing like clinical studies, along with my clinical, practice.
Yeah.
But actually, it has been like already 5 years since I was in EarCAD. But at that time, I conducted several review, and I published like review for the radio mix
Yeah.
in hepatocellular carcinoma, especially.
Yes, I saw that. Yeah.
Right? And in that review, like I encountered a lot of difficulties and challenging in this field. For example, almost all studies are retrospective design and lack of external validation and small sample size or insufficient imaging standardization,
So
and no, for
before
example,
you
blah,
go
blah. Yeah.
before you go further, that's helpful, I think, for the listeners that we do have. When you do a radiomic study, say you want to look at CT scans,
Mhm.
how many patients, how many CT scans is a good number to get? Do you need 10? Do you need
Mhm.
100? Do you need 1,000? Do you need 10,000? What is kind of like a minimum number in each group?
Minimum number.
Like a minimum number that in
All
your
right.
brain is required for a decent study on
Yeah.
radiomics?
Yeah, I would say like more is better, to be honest.
Yeah.
Yeah, because most of the studies I reviewed are like less than 100 patient.
Yeah.
Yeah, and average like a little bit around 100. So I feel like we need to do a bigger study, large amount of patient, and validation study, and with mouth-centric institution. Yeah.
Now, do you have, are you able to get grant money to do research on this? Is the government pushing artificial intelligence? The reason I mentioned it is I'm part of a consortium where we just got about 4 million euros from the European Union to develop guidelines for the introduction of artificial intelligence
Oh.
in Europe. There's a big push in Europe for this. And I know in South Korea, there's a big push for this. I know in China there's a big push for more and more AI research. But how do you feel the
Mm.
Japanese government is doing in supporting people like you who are interested in this field?
Yeah, currently like the government like started pushing this kind of research, but it's just starting point. So it's kind of a little bit uh you know get more improvement. We need to get
You
need
would you,
more
you would like
improvement. Yeah.
you would like more
Mm.
money. You would like them to.
Actually, yeah.
Yeah, they're a little bit stingy. Yeah, I understand. Now, what about with industry? Are you able to find industry partners like Olympic,
Mm.
like Fuji? Do they help you do research in this field? Are there any companies in particular in Japan that do a lot of AI
Hmm.
research? I
Yeah.
can't remember, but there's actually a company I just saw in
Yeah.
Japan that does augmented reality
Yeah.
in real time. Do you know this company or do you work with
I
them?
think so. Yeah, yeah. I think I'm working with them. Like that's called an out, right? Maybe.
I think so. Yeah. Yeah.
Yeah. Maybe they exhibit like in Sages or some
Yeah.
conferences. Yeah.
They already have a product on the market, right? That is
Yeah, exactly. Yes.
that is able to it's able to identify blood vessels and things like that of the liver.
Yes, not in liver, but colorectal surgery and stomach surgery. So they maybe identify like the tissue, like vessels. Yes,
Yeah,
etc.
yeah.
Yeah.
Oh, very nice.
Plain. Hmm.
So that's good. So you already work with them. So you're in Japan. Do you feel like surgical scientists like yourself, are you
Hmm.
are you supported to do this type of research? Are you more supported in a private hospital or more supported in a public hospital, or does it not depend on that?
Actually, easier in the university hospital to get the government grant.
Okay.
Yeah. So maybe better in working in the university hospital actually.
Okay.
But I also now belong to university hospital, so maybe yeah, I can work with them.
So how does that work when you work in a private and you still like I do the same thing, right? I have my academic title in Germany as a professor of surgery, but I'm currently working in a public hospital in Paris, and I also work at a public hospital. Um,
Mhm.
does the university give you any support, or is it mainly when you're going for grants that being part of a university helps?
Actually, now my position is not like a permanent, so maybe I need to move maybe within a year or 2 years. Maybe the next step will be the university hospital.
Okay.
Yeah, that's my
So
goal. Yeah.
So we both know Takeaki Ishizawa. He was at Tokyo University, I believe. He's now at Osaka, right?
Yeah. Yeah.
So how is it for, how is it doing research? Is it easier to find research money in Tokyo? Is it easier in Osaka, or does that not really make a
Yeah.
difference?
Yeah, it's not really they make different, but yeah, maybe it's same. Totally same. Yeah. I think so. Yeah.
Now, do you also do transplant surgery?
Nowadays, no. Yeah. But when I was in university hospital, yes. Yeah.
How do you see artificial intelligence impacting transplant surgery? Do you think it's mainly in like
Mm.
um,
Yeah.
donor selection? Will it
hmm
be like real-time computer vision analysis
hmm
of specimens? Will it be
Yeah.
maybe on radiomics? Will it be on
Yeah.
analysis of data points? What do you see is the future of AI in transplant surgery, or the most
But I
interesting things to you?
but I think it's not good point to discuss actually because I did review for the radiomics in the HCC.
Yeah.
And especially in HCC, we need to, select the patient, go for a transplant or go for the resection or go for the other therapies. But the important point is to, know the, prognosis or, early recurrence potential or, these kind of things, you know, in a preoperative evaluation so
Yeah.
that we can stratify the patients to go for each, options, I think,
Gee,
using.
Yeah, no, so that's a good point because I'm actually I'm going to write another grant that's coming down the pipeline, and I'm working with this company, and we're actually trying to decide whether we should do primary liver cancer,
Mhm.
whether we should do metastasis from colorectal, whether
Yeah.
we should do pancreatic cancer with metastasis to the pancreas. And actually, you bring up a good point in the sense that if we could use radiomics to decide better,
Mhm.
maybe HCC is the way to go, because if we could use radiomics and we could decide not only which patients the tumor has a bad biology or a good biology, whether the tumor will maybe respond better to chemotherapy or immunotherapy or no or not, but if we can add another factor, which patients should not get liver resection, should not get embolization, and they should go right to transplant. I wonder if that would help the algorithm, or would that render the algorithm too complex? Vincent, what do you think?
Yeah,
What I want to do, I always like to mix radiomics and another omics, like maybe
right.
genomics. I won't specify the actual thing we're looking into, but if we fuse these things, would it be better to look at metastatic disease, primary liver cancer, or maybe something like HCC, where not only is it an oncological problem, but there's also this element of transplants? You think that'll make the algorithm harder to make or easier to make?
No, I think this is a multi-omics problem set, as you mentioned, because survival has more to do with human biology than many things. The surgical procedure is a technical, a technical exercise, but the preoperative workup to see who would benefit best, as you mentioned, from transplant versus something else, is all a multi-omic world. Now, what also is interesting on the metastatic side is survival for metastatic colon cancer has a lot to do with nutritional status, likelihood of somebody post-therapy complying with the care plan. A lot of people don't survive not because of the surgical treatment, but because they just can't follow the care plan with the other comorbidities. They have diabetes, they have hypertension. So if you don't look at all of it, it's hard to select the optimal patients. So this is a very exciting multi-omics problem set. See what you guys think, but I think it's a very interesting one.
I always like to use AI with cancers that we're less successful with, right? Colorectal metastasis. I feel, obviously we haven't solved the problem, but we're a lot further on than we are with, say, pancreatic metastasis, right? That said, it's very hard to get samples and specimens for things like people with metastatic pancreatic cancer. Do you now at your private hospital, do you do transplants, or you're just doing liver resections for cancer? Not you, but
Uh,
do they do transplants at your hospital currently?
in my hospital, no transplantation system now program. So just, the resection, oncological resections. Yeah.
Well, I think,
Yeah.
I think in the end, another benefit of dealing with hepatocellular carcinoma, when you
Yeah.
want to look at things like genomics and
Mhm.
when you need tissue, what's nice about liver transplants is
Yeah.
for hepatocellular, you remove
Yeah.
the whole specimen, so you have the entire specimen. Um,
That's right.
so that's probably a benefit that I have to take into account. And
Yeah.
it makes more sense to do hepatocellular carcinoma,
Mhm.
for this reason. Yeah, interesting.
Yeah. Maybe as you know, in Japan, like donation from deceased donor is quite less compared to the other countries, Western countries.
Right, right.
So dominantly we do living donor liver transplantations. Yeah. But yeah, maybe if whole liver investigation is quite needed. And also I want to emphasize like to do radio mix for background liver, you know, instead of tumor only. But adjacent background liver is also important to know the recurrence potential or the liver function, renal liver function or something like that. So
Oh,
we need to compare. Yeah.
so you're saying background? You mean like
Yeah.
the normal liver, the normal liver, so you can look at that also.
Yeah, yeah. For example, like CT scan, we need to, not only the liver tumor, but also like background liver is good to, investigate for the, the
That's
patient prognosis for the HCC patient. Yeah.
that's a good point, because then you can kind
Mm.
of tell who's a good candidate for a resection and
Mm-hmm.
who should be pushed towards a whole liver
Transplant.
transplant. Yeah, interesting.
Exactly. Yeah.
Complicated, but do
No,
you?
Andrew, I just wanted to ask a quick question
Sure, of course. Sorry.
for our audience. If Tiger, could you give us an example of where specifically you're using augmented reality? So, you have to work up your patients, obviously, then they arrive in the operating room and you perform either a transplant or a resection. Can you give us just an example of where augmented reality has made a difference for you,
Yeah.
before you used it and now that you use it? Just,
Yeah.
what are your thoughts on
Th-
that?
That's quite a good point to discuss. And actually, in a clinical setting, for unfortunately, maybe there is no, you know, sufficient quality of augmented reality in nowadays still. But we now have a lot of startup companies to develop this kind of augmented reality. For example, like using a hologram. Maybe have you ever heard about that?
Yeah.
Hologram, yeah, like to create
Oh,
3D model in the air using this kind of 3D goggle during the operation. So we need to we don't need to even touch the screen or something like that during the operation to see the navigation model. But nowadays it's not so clinically relevant for the moment. But maybe when I was in EuroCAD, there are a lot of engineers to work on that to, augmented reality in the pig model, actually, pig model. We could see the, vascular anatomy, super imposed to the liver itself. For example, this kind of maybe usage are the way to go, actually. Yeah.
Thank you.
Mm.
yeah, interesting.
Mm.
So I'm trying to I'm trying to think. When you worked, well, were you exposed to blackjack also? did you know about Blackjack, the manga? Blackjack?
Blackjack.
Yeah.
Yes,
So your generation
of
also
course.
knew about this, really?
Yeah, of course. Yeah.
So Vincent, I can't remember if I told you, but there's the Walt Disney of Japan is Osamu.
Yeah,
Tezuka?
also Tezuka Osamu. Yeah.
Osamu. He kind of was forced to go to medical school by his parents, probably
Hmm.
very similar to Taiga and myself, but that's another topic. Uh, but after he finished medical school, his passion was drawing, and he became a very famous artist. He developed like the big eyes, like that was like that whole, that's all from him. And
Hmm.
his most famous work is Astro Boy, which you probably remember Astro Boy.
Astro
But
Boy. Yeah.
but my favorite, and maybe every surgeon in Japan, is Blackjack. It's a character where the main character is the surgeon. He
Hmm.
he always dresses in black. He has scars all
Hmm.
over his body because he was like operated on as a child and saved by a surgeon. That's why he became a surgeon. He only does private practice. He like people have to pay him cash.
Hmm.
He's the world's best surgeon, but he doesn't. He operates without a license. Like it's this surreal character, but it was Tezuka Osamu's like kind of his passion project. He did it for about 10 years. It's absolutely incredible. It's very radical. There's even one of his at one point Blackjack needed a skin graft, and the only person for whatever reason that would give him the skin was this little boy who was half black, half Japanese. So on his face, part of his face is he's got a patch like that's darker over the rest of his body.
Wow.
And that
Yeah.
that little boy grew up
You know
to
very well.
oh yeah. I read everything. I read everything. He became a revolutionary for animal rights. Like there's it's very he even Blackjack made his assistant from a teratoma.
Wow.
He removed a teratoma and then he turned it into this little girl, bone, hair. It's incredible. And the reason I love this story so much is I was at Columbia at the time when I was reading it, and Blackjack goes to Columbia in Manhattan. And the American surgeons are very arrogant, and of course Blackjack saves the day. But years later, a very famous transplant surgeon from Japan started working at Columbia, and he was doing incredible things. He would, remove the liver, put it on the back table, cut the liver in half, sew it back together, stick it back in the patient, just like Blackjack, the real Blackjack, to the point where I believe in Japan, people, I don't know if you know, do you know Kato? People would call him Blackjack in Japan. Did you ever hear of this doctor, or you must have? You
Oh,
probably
of course. Dr. Kato.
you probably know him personally.
Yeah.
And so, Vincent, just to kind of finish what's so interesting about Cato, I mean, it was as the world's most incredible open surgeon or open transplant surgeon. He actually developed it was COVID, right? He was very sick in the intensive care unit and wrote about his experience in an article. And like he learned from it. Like for instance, he will never put a rectal tube in a patient again after his experience of how horrible it was. But luckily he survived. I think
Wow.
he might have had to have a tracheostomy, things like all incredible things. But in many ways he became Blackjack, because Blackjack as a child was in a horrible accident, went through like a horrible experience, and came out of it better. And just like Cato, it's an incredible story. And and with that, Vincent, do you have any last thoughts?
No, it's very exciting. I'd like to follow up with with our guest and talk about some augmented reality, maybe potential collaborations we could have.
Yeah, great. So Taiga, we'll be in touch.
Yeah.
I think it would be great to have you. I didn't tell you yet, Vincent, but I'm hoping to create a position for Taiga to kind of be the chief of the junior editorial board, like chief editor of that, so he can kind of help us push AI even further.
Nice. That'd be fantastic.
Yeah, I think so. But I'll be in touch with that.
Yeah.
Just give me some time, but that's
Yeah.
that's probably where we're headed. Okay. So
I'm eager to contribute. Thank you.
great. So thank you so much for staying up late. Say hi to your father. He may remember me. He may not remember me. I met him a few times.
He remember you. Yeah.
Yeah, I saw him not too long ago, actually, but the first time I met him was when I used to work at Cornell in 2006. So I
Okay.
remember him there a long time ago. Yeah, he's great.
Maybe he could be a guest on the show, Andrew.
Oh wow, yeah, that would be. We would love to have your father one of these days. I know he's a busy man, but we'll wait until you're chief of your editorial board, and then we'll have you interview your father.
Yeah.
All right. Thank you.
Great. All right. Have
So
a
maybe yeah, we'll
sorry?
see in ILLS 2025, maybe in Korea, maybe.
Yeah.
Right.
Will you be going?
Okay.
You'll be
Yes.
there?
Yeah.
Okay,
Yeah,
great.
I'll be there.
I'll see you there.
So please keep in touch. Yeah.
We will be. Get some rest. We know it's late.
Thank you.